Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
This program is presented by Medscape Education Global.
Hi, everyone. I'm Tim Garvey. I'm an endocrinologist and professor at the University of Alabama at Birmingham and director of the Diabetes Research Center there. Really welcome to this exciting program entitled ADA Highlights, the weight of evidence for emerging combination therapies in obesity and diabetes care. As you know, there are many unmet needs in obesity and diabetes beyond the treatments we currently have available in the clinic. These are complex diseases, obesity and diabetes, and it's likely we need to target multiple pathways to better help our patients. And to address this, there's now an emerging field of combination therapies, and we'll discuss some of these very novel therapies today. It's my pleasure today to present to you the results of the REDEFINE 1 and REDEFINE 2 clinical trials. These trials assess for the first time a very novel combination of two medications that are administered together. One is one of our old friends, and that's semaglutide. The structure of semaglutide is shown on the right here. It's analogous to GLP-1, the human GLP-1, which binds GLP-1 receptors, which suppress appetite in feeding centers in the brain. The second drug is, for the first time, is cagrilintide, and this is a long-acting amylin. What's an amylin? Well, amylin is co-secreted with insulin from the beta cells in the pancreas. So it's stimulated by nutrients, by glucose, and it travels to the brain, acts on different neurons in the brain to suppress appetite. So the hypothesis here is that the combination of these two drugs will lead to increased efficacy. And that's what we tested in the REDEFINE 1 trial. This involved patients with obesity, but not diabetes. There were patients with prediabetes, but not diabetes in this trial. There were 4 arms to this trial. Subjects were randomized to either placebo, cagrilintide alone, the long-acting amylin, semaglutide alone, or the combination that we call CagriSema. They were treated for 68 weeks. The inclusion criteria were either men or women, adults, BMI greater than 30 or BMI greater than 27 with at least one complication. The main endpoints were weight loss and safety, as I indicated. And we'll get right to efficacy for weight loss. Here we're looking at percent weight loss over the 68-week course of the trial. The top curve in gray is placebo. The green curve is cagrilintide alone. The blue curve, semaglutide alone. And at the bottom, the darker curve is CagriSema. And you can see much greater weight loss with the combination CagriSema, leading to 22.7% weight loss at 68 weeks. And it looks like it hadn't quite reached equilibrium. There may be additional weight loss if the study was extended. So this is impressive efficacy. Let me show you some other aspects of efficacy, and that's categorical weight loss. So these are the percentage of patients that lost different thresholds of body weight, greater than 5%, 10%, et cetera. Essentially all patients, close to 100% of patients lost 5% or more of their body weight. Nearly more than 3/4, 78% lost 15% or more of their body weight. And it's really at these higher levels of categorical weight loss, greater than 20%, 25%, and 30%, that we see greater efficacy of the combination CagriSema over the monocomponents, semaglutide and cagrilintide alone, essentially doubling efficacy over semaglutide alone. So greater than 25% loss of body weight, 40% of patients, and 23%, more than 1 in 5, lost 30% or more of their body weight. So very impressive efficacy here. And let me give you one more piece of data. These are shifts in body mass index. As you know, we classify obesity as overweight and then class 1, class 2, class 3 increasing degrees of body mass index. So here's before and after in placebo. You can see patients are kind of stable, remaining stable within their class. In contrast, in response to CagriSema, 56% now are no longer in the obese category. 33% have overweight, 23% have normal body weight. So a marked shift in BMI towards healthy, normal or overweight levels from very much higher BMI levels. So that was the data in patients with obesity and non-diabetes, REDEFINE 1. REDEFINE 2, it was patients that had both obesity and diabetes. And I'll preface this, regardless of the intervention, the weight loss intervention, patients that also have diabetes generally lose about 30% less weight than patients that have obesity and without diabetes. So let's go into this trial design, much simpler, 2 arms, patients randomized to placebo or the combination CagriSema. These had to be type 2 diabetics with baseline hemoglobin A1C 7 to 10%. So let's just jump right to efficacy shown here. Again, percent weight loss over the 68 weeks of the trial. You see the weight coming down very nicely. You can see at 68 weeks, CagriSema led to 15.7% weight loss in these patients. So very nice efficacy here in patients with diabetes. The categorical weight loss shown here, 80, almost 90% of patients losing 5% or more of their body weight, over half losing 15% or more, and 30%, nearly 1/3 losing 20% or more of their body weight. And I can tell you this is very good efficacy in patients with diabetes and obesity. And of course, there was a change in the hemoglobin A1C that was very favorable as well. Hemoglobin A1C came down nearly 2% units from a baseline of 8%. So they were really getting good glycemic control as well as the weight loss. And I can tell you a lot of these patients reached our hemoglobin A1C targets of less than 7% and also less than 6.5%. So here we're treating both obesity and diabetes with this weight loss medication, if you will, CagriSema. In both of these studies, REDEFINE 1 and REDEFINE 2, there were marked improvements in other cardiometabolic disease risk factors, pronounced decrements in blood pressure, in lipids, the CRP, the inflammatory marker. So we're improving cardiometabolic health as well as dealing with obesity and in REDEFINE 2, the glycemia of type 2 diabetes. Safety, we're looking at GLP-1 based drugs, so most of the adverse events were gastrointestinal, nausea, vomiting, constipation. In about these higher than placebo, the very infrequent was there a necessity to discontinue the medication because of these side effects. They were generally mild to moderate, as we've seen with other GLP-1s, occurring early on during dose escalation and then waning away. So reasonably tolerated as we might expect. And so thank you very much. Thank you very much.
Hi, I'm Domenica Rubino, Director of the Washington Center for Weight Management and Research in Arlington, Virginia. So, one of the concerns that we have with weight loss intervention is that weight loss, when we get weight loss, it includes both loss of fat and loss of lean mass. So, when an individual undergoes caloric restriction, regardless of the method, lean mass loss accounts for about 25 to 40% of that total loss. Given this concern, our attention has been focused now on pathways that regulate skeletal muscle as a target for drug development. First of all, bimagrumab blocks activin signaling pathways. Now, activin signaling pathways are involved in both muscle growth, it inhibits muscle growth, and actually drives lipid storage. So the idea is that bimagrumab will inhibit activin signaling, which then leads to increased muscle growth and actually decrease fat mass. And the important thing here is that the mechanism is not dependent on central nervous system effect, not dependent on appetite or satiety. So now let's take a look at the BELIEVE Phase 2 study, which is looking at the impact of bimagrumab, semaglutide, and the combination of both. Now, this is a really busy slide, all right? So I'm going to take you through it. So first of all, there are 3 basic groups. all against compared to the placebo group. So the primary treatment was 48 weeks. There was the placebo group. There were 2 doses of bimagrumab, the 10 milligram and the 30 milligram dose. Then there was open label semaglutide, which is subcutaneous injection of 1.0 and 2.4. And then there was the combined group, the combination group of bimagrumab at the lower dose with semaglutide at the lower dose. Then they did the higher dose of 30 milligrams of bimagrumab with semaglutide 1.0, and then those respective doses against semaglutide 2.4. So we're going to look at data from the 48-week completion period, but then there also was an open label extension of 24 weeks in which the placebo group then went over to the bimagrumab 30 milligram dose, and then they were followed after treatment withdrawal. Now, everyone received dietary intervention with a calorie deficit of 500 calories. They were encouraged to walk, and also DEXA scans to look at body composition. So the BELIEVE study, we're going to look at this briefly, but you can see at the highest dose between bimagrumab at 30 milligrams and semaglutide at 2.4 milligrams, there was 20.2% weight loss at 48 weeks. You can see where semaglutide at 1 and 2.4 hits with a baseline weight loss of 11 to about 14.8%. And bimagrumab alone also resulted in weight loss. You can see 5% weight loss and 9.7 at the highest dose of 30 milligrams. But let's take a look at total body lean mass, and this is what we're all very excited about. When you look at bimagrumab alone, you actually see an increase in lean body mass of about 2.3 to 2.7%. In the combination, you see a range of less lean body mass loss compared to semaglutide. So with the combination group, we see 1 to 2.8% change in lean body mass relative to that loss of body fat, compared to semaglutide, where you're actually seeing 7.9% decrease in lean body mass. So in summary of efficacy, a couple of key bits at the endpoints here. In the combination between bimagrumab 30 milligrams and semaglutide 2.4 milligrams, we see a weight loss of 22%, and we see fat mass loss of 45.7%. And you can compare that over the left compared to sema alone and bimagrumab alone. Additionally, with bimagrumab alone, we see an increase in lean body mass of about 2.5%. Compared to semaglutide alone, in which we see a range of lean body mass of minus 7.4% to minus 9.2%, we see much less lean body mass loss in the combination group, resulting in about 2.9 to 2.6%. And when you look at percent of total weight loss due to fat mass, you see in the combined program, you see about 92.9% loss. 70% of people were able to achieve greater than 20%. And those with greater than 30% fat mass reduction on DEXA were 94% in the combined group. What about metabolic outcomes? Well, Dr. Aroni showed with the combination group, we saw a great decrease in visceral adiposity and waist circumference of minus 21.7 centimeters. Additionally, we saw inflammatory markers with the greatest reduction with the combination therapy approach, both in decrease in CRP and increase in adiponectin. These patients did not have diabetes. However, we did see a decrease in A1C. One thing that we expected from different studies is that semaglutide, we see a decrease in cholesterol. However, we see a slight increase with the combination therapy, and we see an increase with bimagrumab. And this is something that there's going to be future research in understanding the implication of elevated cholesterol. However, triglycerides were decreased the greatest in the combination group, as well as systolic blood pressure and diastolic blood pressure. Well, what about safety? Because that's always our concern. From an adverse side effect standpoint, first of all, the side effects, where the majority of them were actually mild to moderate in severity. The blue arrows are indicating the typical side effects that are seen with bimagrumab, which is muscle spasms. We see increase in diarrhea and some increase in acne. That's an overlap of the combination therapy where we do see some nausea, although there was a greater amount of nausea with the semaglutide group, as we've seen previously. And constipation looked to be about the same. In fact, with the combination group, it was a little bit less, with a minimal amount of vomiting, more vomiting seen in semaglutide alone compared to the combination group. But overall, it was thought to be actually relatively safe. Thank you for your time.
Hello, I'm Dr. Donna Ryan, and I'm Professor Emerita at the Pennington Biomedical Research Center in Baton Rouge, Louisiana. As you all know, and you've heard from my colleagues, obesity is a complex chronic disease, and different people respond differently to treatments. It's likely that targeting one pathway won't be enough for treatment in everyone, and we need lots of different molecular approaches to help with weight management. One approach to improving treatment is to target two different appetite regulating pathways, and this is being done with the Maritide Clinical Development Program. So, Maritide is a very interesting molecule. It's a monoclonal antibody directed to GIP. It's an antagonist of the GIP receptor, which has everyone very interesting. But attached to that monoclonal antibody are two GLP-1 receptor analogs. And so it's a conjugated peptide. So the advantage of this approach would be that it could be given monthly or even every 2 months. So it has a very long half-life on average. So this phase 2 study, one was in a cohort of patients with obesity, and the other was in a cohort of patients with obesity and type 2 diabetes. So in both of these studies, treatment was extended for 52 weeks, and patients received monthly or less frequent dosing schedules. There were 11 arms. The initial study started with just no dose escalation. So patients were randomized to receive either placebo, 140 milligrams, 280 milligrams, 420 milligrams, and that occurred in both the patients with obesity without diabetes and those with diabetes. But for the patients with obesity alone, there was another arm for 420 milligrams every other month. Uh, Early on in the study, it was determined that a dose escalation was probably going to be needed to manage tolerability. So there were two additional arms, one starting at 70 milligrams and then going up to 420 milligrams, and the other with a longer 12-week dose escalation of 70 milligrams. And then up to 210 milligrams, and then up to 420 milligrams. So, very interesting results from this study. And what was most impressive was the amount of weight loss. So at 52 weeks, the top weight loss was achieved 19.9%. So roughly 20% weight loss on this new molecule. And even more interesting was that the weight loss trajectory had not begun to flatten out. So we do not know what the ultimate weight loss is going to be with Maritide. For the patients with type 2 diabetes, the baseline A1C was 7 to 10%. And in those individuals, we also saw a very interesting weight loss trajectory. About 17% weight loss was the top weight loss, and that occurred at 52 weeks. So this is more than we're used to seeing with patients with type 2 diabetes, and it's a little bit unusual to see this amount of weight loss. In addition, the average A1C reduction in the study of obesity with diabetes was about 2.2 percentage points of hemoglobin A1C, along with the improvement in weight and in glycemia. We also saw, as expected, improvements in many cardiometabolic parameters. And so, in terms of serious adverse events and safety measures, it was what we would expect for drugs in the GIP GLP-1 class. So, what about tolerability? A modified index of nausea, vomiting, and retching was used. And so this is called the MINVR, MINVR. Patients were asked to fill out a form, and they were asked, how many times in the last 24 hours have you had vomiting? How many times in the last 24 hours have you had nausea? How many times in the last 24 hours have you had retching or dry heaves? So this is it's a tool that's used in cancer chemotherapy, and it produces a lot of granularity around the nausea, vomiting symptoms that are associated with the GLP-1 receptor analogs. So the Minver was used daily for 7 days after each dose up to week 12. In the highest dose that was given with no step up, no dose escalation, the vomiting rates were up to about 85%. But with a one-step dose escalation, they fell to less than 50%. So we already saw that a dose escalation was having an effect, but we didn't feel like we had the right dose to go into phase 3. So what happened was the study conducted a phase 1 PK low dose initiation study. Group 1 had a starting dose of 21 milligrams, Group 2, 35 milligrams, and Group 3, 70 milligrams. And then after 2 weeks, there was an increase, and all 3 groups received 70 milligrams. After an additional 14 days, on day 29, everyone received 350 milligrams. So what we showed was when the 3 initial doses were given, there were, as expected, different levels of plasma concentration of maritide. But with that second dose, when everybody was given 70 milligrams, and there was a beginning of overlapping of the PK curves of the plasma concentrations. So what we did is we paired that with the Minver, and what it became fairly clear was that group 1 with the 21 milligram starting dose, that was nearly ideal. The rate of vomiting, constipation, and diarrhea was 2.4%. Now, the nausea rates were a little higher, about 24%, but they were regarded as mild and transient. But what happened when we increased the dose to 70 milligrams? The group that was on 21 milligrams had the GI adverse event profile that was really similar to the other 2 groups. And it suggested that we should have an intermediate step. So what this does is it really informs how we're going to do phase 3. So the decision has been made to start with 21 milligrams, 2 weeks later to increase to 35 milligrams, an intermediate dose, and 2 weeks after that to 70 milligrams. So after 4 weeks on 70 milligrams, patients will be randomized to 3 different doses for the phase 3 study. Thank you very much.
Well, hello, everybody. It's Tim Garvey again, and this time I'm joined by my colleagues Donna Ryan and Domenica Rubino. We're going to continue our discussion on combination therapy and the progress that's been made, presented here at this year's American Diabetes Association meetings. And Domenica, why don't we go to you to kick us off there? What do you think about the strategy here of these combination medications?
Well, Tim, I'm really, really excited about this. I mean, having been in this field for quite a long time, we now have so many tools we've learned. And in fact, all of this development of this therapy with obesity has actually helped us learn more about the brain, about the signaling back to the brain, more about the treatment of obesity. So now we're going to have so many tools. I'm very excited about this opportunity to have new medications.
Right. I don't think this should be surprising. And we do this with other disease entities. We combine medicines for diabetes, we combine medicines for hypertension. And so when you combine medicine with 2 different mechanisms of action that can be additive in terms of the outcome you desire, this is all going to be good for patients. And that's what we're seeing with obesity now, too. I think an unmet need in obesity is a medication that can give us 15-20% body weight, because we know that's going to lead to a lot of health benefits, but to be well tolerated.
I think more and more that tolerability is going to be the emphasis.
Right.
And, right now, I think our strategy in phase 3 is to really push these doses up for the purpose of writing a label. And writing a label in as short a period of observation as possible, because time is money in obesity trials. But I think we need to really rethink that to some extent. Domenica, you've long been a proponent of start low and go slow.
Well, I think clinically that's what we see. We have to be flexible because of the heterogeneity in response. And also, the reality is at lower doses, people worry a lot about adherence now to these molecules, and we hear that all the time. I mean, obviously, there's economic reasons why people can't continue these medicines, but one of the reasons is actually the adherence and tolerability, right? And so, if we can do these studies where we allow that flexibility, which is a new thing, we saw that in many of the programs now, where we're allowed to go down in dose to see how people tolerate it, and we're finding out that there's greater adherence with, better tolerability. And to your point, Tim, we don't necessarily need 30% weight loss. I think this 15 to 20% weight loss is really important. We know we get tremendous improvements in health outcomes.
This, what you said, Domenica, about smaller doses sometimes being effective. Patients responding very well to low doses and losing as much weight, if not more weight,
Mm.
than others that finished on the full dose. And we see this in the real world practice as well. So um, just remember, obesity is a heterogeneous disease, and responses to these medications will vary. And we want healthy weight loss, not too much or too little, I suppose.
Yeah, the really amazing thing about this ADA is not just the number of products that are put before us. It's about much more than weight loss. It's
Absolutely.
about improving body composition, improving organ function, and we really need to sort of be moving in that direction.
Yeah.
And there's a lot of emphasis on muscle, and that's
Mhm.
good. But I think we don't pay much attention to bone. When you lose 20% of your body weight, you lose about 3% of your bone mineral density as well. And we don't really understand the long-term effects of that, particularly in postmenopausal women and other patient groups. Um, Another reason I like amylin is it also binds to calcitonin receptors.
Right.
We used to use calcitonin to treat osteoporosis, and I think that has the potential to preserve bone mass, just like bimagrumab preserved
Absolutely.
muscle mass. Yeah.
So,
Well,
yeah, what a great meeting.
um,
And I
the emphasis, we tend to talk a lot about weight loss in these trials, but I think a lot of the guidelines call for complication-centric care. So we're there to not just get weight off of patients, we're there to improve health, to get sufficient weight off to improve or prevent the complications of this disease. And the clinical trials have kind of adopted this complication-centric approach where weight loss is not necessarily the primary outcome measure. It's improvement in specific complications like heart failure, cardioprotection, renal protection, MASH, etc. I think with some of these newer agents, we still got to go there and kind of prove. I mean, it's been established for some of our old friends like semaglutide and tirzepatide, but that work still kind of needs to be done with some as these newer agents come on board as well.
Yeah, and I think we're expanding on, the FDA has had us focus on quality of life, right? But there's going to be a greater expansion in function, right? So it's not just preserving muscle, but we want to make sure that people actually function better because that's what's important. That's why we're doing what we're doing.
Hugely important.
And we're learning so much more about this disease as we better understand these new medicines. Listen, we have come in the last 10 years, this is perhaps unprecedented in the history of medicine to have this kind of evolution
Yeah.
in terms of our understanding of the disease and the therapeutics we have. Maybe the discovery of insulin, it might have had the same impact, but I didn't expect us to move this quickly, this far, this
Fast, this
quickly.
far, this
No.
fast.
Yeah.
And Dominica, what about patients? How are patients responding to all these things happening?
I think fundamentally patients are very excited. I think a lot has changed. People are much more engaged in accepting that there's a very strong physiologic protectiveness over weight. I think it kind of speaks to their sort of gut feeling, if you will, that they didn't think it was all about willpower themselves, right? Because it feels like it was beyond them. So I think they're very open to therapies. I would say that one of the problems that I hear from my patients is the affordability, the economic coverage for it. And unfortunately, they then feel a bit stigmatized because, here's this medicine that could really help me, and yet I can't afford it or it's not covered by insurance. But I think, the internet in many ways has been good. Patients are actually learning quite a bit about this, and I think they're feeling validated. But I think the next great leap is to actually have these medicines available for everybody. Because I would say, as a physician, there are many people who could benefit from it, but they have no coverage whatsoever. And that's going to be the big challenge as we move forward.
Access, access,
Access.
Yeah. Domenica, you mentioned the advantages of social media, but that's a double-edged sword.
Correct. No, I would say that's true. I mean, one of the things I notice with my patients is that I would say 10 years ago, if they had lost 30 or 40 pounds with these medicines, they would have been thrilled. But now they look on social media and they see actors who, went from a size 4 to a size 0 and misuse of the medicines, and they still feel like they're behind and they're stigmatized. And there will be a whole bunch of issues for us in terms of body image and stigma and dysmorphic issues with the body. So we have a lot of challenges for sure.
I don't like people comparing this to bariatric surgery because the populations are so different. In bariatric surgery, the indication is a BMI of 40 and up. We're treating patients BMI 27 and up.
Yeah.
And so it's a different thing, and we should not expect the same percentage weight loss.
Agreed.
Right. But there's still a role for bariatric surgery.
True. That's why we need all these tools. That's why it was so
Our work
exciting.
cut out for us.
Yeah.
I think there's so much progress on understanding the structural biology and the receptor biology and developing the drugs. That is going great. But Tim, we need better guidance. We need better guidance on who to treat and when, and how should we judge success?
100%.
What are the right targets?
Yeah, I think that we've realized over time we need more work in that area. I mean, but listen, we're so excited by some of these, the research that we've discovered and the new knowledge we've gained at this meeting. And I think we're going to bring this to a close. We're anxious to get back right in there and go to these meetings. So we really appreciate your attention and thank you for the care that you provide these patients. It's our privilege to be able to speak with you today.
This program was presented by Medscape Education Global.